Okay. Good morning, everyone, and welcome and thank you to everyone who is attending in person and online to our Quality Improvement and Partnerships Day, part of Celebrate Research Week. My name is Tiziana Rivera, and I'm the Executive Vice President for Quality Research and Chief Nursing Executive here at Osler. Before we begin, I'd like to take a moment to acknowledge the land on which we are gathered. We acknowledge that our health system is situated on the traditional lands of the Huron-Wendat, Haudenosaunee, Anishinaabe, and Mississaugas of the Credit First Nations. We respectfully recognize a multitude of distinct First Nations, Inuit, Métis, and urban Indigenous peoples who are the original caretakers of the lands and waters known as Canada. Indigenous peoples' knowledge, wisdom, and traditional practices are invaluable enrichments to society, past, present, and future. Indigenous peoples continue to experience injustices due to colonialism, including intentionally harmful and unjust healthcare and research practices with impacts that contribute to intergenerational trauma. Grounded in equity, diversity, inclusion, and health justice, we lead with respect, service, compassion, and collaboration. With gratitude, we commit to cultivating authentic relationships with Indigenous peoples, caring for the land, educating ourselves on Indigenous cultures, providing care with cultural humility, and respecting Indigenous ways of healing. It's truly a pleasure to open today's session focused on improving patient care, the patient experience, and healthcare systems. This is really connected with the mission of Celebrate Research Week and reflects who we are as an organization, a learning health system that grows stronger through curiosity, collaboration, and evidence-informed practice. Research Week is a powerful reminder that when brilliant minds come together, each with their own expertise, experience, and perspective, we create something greater than any one of us could achieve alone. I often think of our work as an orchestra. Quality improvement provides the steady rhythm. Research brings the harmonies that deepen our understanding. Partnerships contribute the soaring notes that elevate our work. And when all elements come together with precision and passion, we produce a symphony of better care for patients, families, and communities. Today's program reflects the power of this collaboration, innovation, and continuous learning. We'll hear from leaders across the province and from our own teams who will be sharing how quality improvement and partnerships drive better care for patients, families, and communities. I want to take the opportunity to thank Patty Rempel, Dr. Veronique Boscart, and Sofia Ramirez for their exceptional work in creating and making this entire week possible. I also wish to thank all our presenters for tuning in to this event in sharing and so generously sharing your talents. I'd like to invite Dr. Greg Rutledge, Chief of Staff and Executive Vice President, Medical and Academic Affairs, to welcome and introduce our keynote speaker this morning. Thank you.
Thanks, Tiziana. I'm excited to be here today. Another great morning of what has been a great week. So thanks for having me. And a pleasure to welcome you all to the keynote address today. We're gathered at an exciting moment for Celebrate Research Week and recognize the incredible work happening across William Osler Health System and in our communities, an initiative led by the Osler Research Institute for Health Innovation. This week brings together researchers, clinicians, community partners, and learners to share discoveries that are changing how we deliver care, improve patient outcomes, and build a healthier future for all. This week brings together, at Osler, research isn't something that happens in isolation. It is connected to our mission and allows us to deliver safe, equitable, and compassionate care informed by evidence and driven by innovation. Celebrate Research Week reflects that mission. It's about connecting people and ideas across clinical teams, academic partners, and community organizations to move forward together. To help open us this day, focused on quality improvement and partnerships, we're honored to welcome a remarkable leader whose career embodies that same spirit of collaboration, innovation, and service. Dr. Zainab Abdurrahman is the president of the Ontario Medical Association, representing over 43,000 physicians across the province. She is a practicing allergist and clinical immunologist, an assistant clinical professor of Toronto Metropolitan University School of Medicine, and an adjunct clinical professor of pediatrics at McMaster University. Dr. Abdurrahman's background combines clinical excellence, research expertise, and a deep commitment to health equality and equity. She earned her MD at the University of Toronto, followed by residency and subspecialty training in pediatrics and allergy and clinical immunology at McMaster University. She also holds a master's degree in statistics with a specialization in biostatistics, reflecting her belief in data-driven, evidence-informed care. Beyond her academic and clinical contributions, Dr. Abdurrahman has been a strong voice for equity and inclusion in medicine. Her work bridges clinical research, community partnerships, and system-level change, all with a focus on improving health outcomes and creating a more inclusive health system. Please join me in giving a warm welcome to Dr. Zainab Abdurrahman as she shares her keynote on how research, innovation, and collaboration are shaping the future of quality improvement and system transformation across Ontario's health landscapes. Dr. Abdurrahman.
Thank you so much, and good morning. Thank you for joining me this morning and giving me really the opportunity to be your keynote speaker. It's truly a pleasure to be here and to join you during your Celebrate Research Week. It's a time to really come together across Ontario, but really across Canada. This really reflects how the work being done here today together in Brampton across Ontario to really recognize the extraordinary impacts that research has on the health of our communities, because that's really where our focus is. Just as when you think about funded healthcare being central to who we are as Canadians, so are our commitments actually to research and equity. This week strengthens that. It strengthens the commitment, and it reminds us all, the power of science and technology and curiosity, that's what really drives progress. That's what's driving us forward. But we need to do that with that lens of equity. And that is kind of where you start to see some of the true beauty coming out of the work that we're all doing together. This week really is fundamental. It really emphasizes the fact that research is not abstract, right? Research, it's not something that you're doing as an exercise. Research is actually happening as a result of the questions that we're seeing as we're walking through our community, as we are seeing patients, as people are walking their lives. This is actually what drives research. It's not happening in distant labs or corridors. It's really centered in communities. That's why we've considered research. That's why we look forward. It's actually an opportunity to strengthen our communities. And so really research it's living, it's evolving, and it gets shaped by how we diagnose, how we treat, how we care. And that's how it improves lives both today and for future generations. As mentioned, I have a varied background in terms of my training, but also in terms of my master's in statistics. And I remember when I did that, I did this at Waterloo, and the professors there were very, very interested in the fact that I wanted to do medicine. I did this before medical school, and they said, this is going to be great because then you're going to speak both languages, because we're often trying to achieve, and sometimes it feels like we're speaking different languages. And that really, for me, cemented the importance, not just of doing research and being involved, but also being involved on other aspects. So some of you might come into research, into healthcare, into innovation from different walks of life. And this is important because we all are going to be speaking many different languages, and we need to be able to collaborate across. And that's actually where a lot of the great work comes to be. And, so my master's is very quantitative, very much statistics. But I'll tell you, some of the greatest projects I worked on was during my fellowship looking at people's experiences and caregiver experiences with anaphylaxis and that initial anxiety. And that was all qualitative research. And so that was learning new research methods for myself. And so that's part of research, is constantly learning new ways to look at problems and expanding yourself. So I really am excited to be here. This year's programming really shows that breadth of work being done and the depth of research in our province, but from community-based studies to groundbreaking innovations and new partnerships. We're witnessing that in Ontario, and that continues to change the landscape, and it changes how the future generations will walk through care, but also for those who are providing care and just how we're going to look at it. And I really want to take a moment to acknowledge Brampton. To be honest, this week began, with looking at the launch of your Osler Research Institute for Health Innovation. And that's another significant milestone for the region and for our province. And I'm just so excited to see how it goes on to accelerate the work of clinicians, as well as scientists and community partners. I might be dating myself, but I often think about that old jingle about good things grow in Ontario, right? And so you really think about that. And you think about this in the place of, this is also where we launched the new medical school with both postgraduate and undergraduate medicine right here as well. So it's a really beautiful intertwinement of the educational part, those who are coming in looking with fresh eyes. And that's really what you need when you're talking about research. It's constantly having someone else say, have you ever thought about looking at it this way? Have you thought about looking at research in a totally different manner? And that's why it's important to have this enmeshing of the education plus the research, because that's really where it comes together. You need those two to continue and to show future generations that they can also be part of research. We want to ensure that research doesn't seem like something far away. It has to be something attainable, and that's something that you can participate in, whether you dedicate most of your life to research or if it's something that you're doing in addition to other work. It has to be attainable, and that's actually where you get a lot of the equity lens as well. When you're thinking about who does research as well, we need to also have that diversity of those who are doing research. Personally, as I mentioned, I'm an allergist and clinical immunologist, and with all my other background, I spent a lot of my career in terms of teaching, mentoring, and working alongside researchers. So I know really firsthand how important it is for the rigorous, evidence and how we pursue this, and how it really takes passion and being very meticulous as well. It requires a lot of parts of your brain. We talk about the art and science of medicine, and people often just say, yes, the science is the research, but actually there's a lot of art that goes into this. Being able to look at, broach the problems, that actually is a bit of an art, and then to be able to link it to what we're trying to achieve. So research is truly the art and science. It's not the separation. People often say research science. It's not. It's actually truly that combination. It's really important for us to see that, because we need creativity. We can't do the same research. We can't keep doing the same things over and over. If not, there wouldn't be research. We'd be done, right? So that's why it's truly that blend of art and science, and bringing it focused on the community, because that's where we're trying to make change. That's who we're trying to actually change things for. And I think about this when I did some of the work within, when I was on the Black Scientists Taskforce for COVID-19 Vaccine Equity. And this was a different way of looking at things. We had at that time, we had to address some of the historical issues as to why populations, specifically Black populations, had a lot of reservations about vaccines. And this is something that I think is also a new way that we're looking at things. In the past, we'd often just say, yes, there were things in the past, but this is really important now. But we're really seeing the importance of establishing trust. And that means going back and saying, you know what, there were some unsafe practices before. We have changed. We have really strong ethics. We have things in place to keep everyone safe, and to do research that is intended to keep all populations safe, regardless of age, gender, race, or where you live. We know that postal codes unfortunately play a huge role in medicine and the care that's delivered. So it's to say that we're looking at that, and we're recognizing that there is bias in our system, and we're trying to do research and trying to provide care so that we are trying to eliminate these biases, these racism that's within the healthcare systems. So you have to recognize that and speak to it. And that's why it's so important when you're approaching these weeks, that there is partnership as part of it. And that's why, in particular, I was happy to speak today, because the partnerships are critical for us to make sure that what we're doing is actually going to provide safe practices for everyone, every single person. And so I'm really happy to see that focusing it on the community base is highlighted this week. Because when we ground our work where we're living, where we're working, we're just going to produce knowledge that's meaningful, it's rooted, it's actionable, and you're going to see it, and it's equitable. And it's that kind of research that really is going to support better care of all kinds. It's going to reduce disparities, and it's going to really foster the trust between patients and the healthcare system, because that's what we really want. We want you to know that we're going to be here for you, and the treatments and our approaches have been considering all of us. So we're also at a really exciting and I want to say challenging time in medicine, but you know what? Sometimes the best innovation happens when we're at those times when it's challenging, when we're trying to say, okay, there's technological transformation, there's digital tools, there's artificial intelligence, there's so much on there. And, you know, sometimes people might think, oh, I need to just kind of keep myself in certain parts, but no, you actually want to lean in to those parts that you don't know about. Artificial intelligence isn't so much scary, but how do we use it so that it is leading to equitable transformation of the healthcare system? How do we lean in to bringing in new views and just different ways of looking at healthcare? You know, we know that how people have looked at what I refer to as really sick care, and how we're trying to make sure that we're also talking about well care, because we don't want it to be that you're waiting and then you're coming and presenting at the hospital. We're talking about keeping people safe and healthy at home and trying to really propagate that and really have that focus. And that's where a lot of the research also is focused on. So really today, I really want to extend my gratitude to the researchers, the physicians, the students, the innovators, and the community partners, because that's who makes this possible, but also the people who we're looking to make their lives better, because we know that that's where our vision is. That's where we're looking to actually make change. So with that, the work that you're doing here is shaping not just the work in Brampton, not just the work in Ontario, but actually leading the work across the country. And unfortunately, due to changes that we have, you know, south of the border, we are going to be the ones who are leading when we talk about science. So we need to continue with our commitment to science, with our commitment to rigorous methodologies, rigorous ethics, and equity, and not straying from this path. So I hope this week is really going to deepen all of our collaborations, all of our challenges, and that's to challenge the assumptions, as well as to continue pushing boundaries. So thank you, and I wish you all a wonderful week of celebrating research. Thank you so much.
Thank you so much, Dr. Abdurrahman, for your inspiring keynotes opening for us. We'll open it up for some questions and answers from the audience or from online. Hey, as I wait for hands to go up, I do have a question for you. So you talked about the art and science of research and how it informs and transforms the care that we provide to our patients and the community. What I find in my role sometimes is that our point of care staff, nurses, nurse practitioners, and some physicians in particular, and even our allied health staff, tend to separate the clinical aspect from their work and the research aspect. What thoughts do you have in how we can better engage our point of care staff to not just apply research, but also do research?
Thank you. This is a great question. And I think one of the things is to actually sometimes show them some of the work that they're already doing is actually sometimes part of research and how they can continue to incorporate it. And, you know, you have to say, what are the problems that you are perhaps encountering in your day-to-day work, which you consider separate work, and say, well, what do you think is working well? What isn't? Well, let's do some quality improvement around this. And then that's also research. And it's really grounded in what people consider as their day-to-day work. And they'd say, is this still research? And you're like, yes, actually, looking at what we're doing and how we're doing it and trying to improve in ways is also research. People often separate and they're like, well, isn't it something in the lab? Isn't there tons of statistics? Isn't there, and say, no, actually, we can ground it in the ways that you work and have it that it's more in your day-to-day lives. And I think that's what it is, breaking down those barriers that research has to be separate and really showing that you can be part of it while doing your clinical day, and it can be incorporated right there at the bedside too. And so trying to break that down, and I think bringing people together in opportunities like this as well, where you can actually talk about it and say, this was an idea we had, this is actually where it came through, and this is now where you're applying it on the wards in your day-to-day lives. And I think showing that knowledge translation is really important. And that's kind of where we talk about the different languages and really trying to speak to each other and breaking it down. So having those opportunities for the collaboration and to also have the ground up research coming up, as well as some of the other questions that come the other way, and showing and reflecting that, I think, is the best way.
Great, thank you. Thanks. Any questions? Okay, so we've got one in the audience.
I just have another question before, but do you have some advice for the younger generation who wants to do clinical work but also research?
So what I would say is, especially when you're starting, give yourself opportunity to check out different ways that people do research. People, like I said, you might think of what you classically think of research, but even for someone that you might be in the community with, say, do you participate in any forms of research? Do you do anything yourself? Do you ever run anything in your office? Wherever you are, ask people about it and see different opportunities. And sometimes you might have an opportunity to do something that's not quite what you thought of. It was something different, and lean into that, right? So like for myself, as I said, with my research project that I did in my fellowship, everyone said, isn't it funny you spent so many years learning all this quantitative work and all this, you can do so much fun, statistics and like all this. Like, yeah, I love all this. But I said, but I'm learning an entirely different new research methodology since I hadn't seen qualitative research. And I was learning about new systems and how to, collect data from conversations, which I thought was very fascinating. And that was also going to drive some more research. So lean into the different opportunities and ask people, because some people that you might not think are involved in research will say, actually, I'm part of a community research collaborative. These are the things we do. Or I've actually been involved in something at the, maybe it's actually in a research lab, and you don't even know about this aspect of their life. So ask people, because you never know who's doing what, and take these opportunities to explore it further.
Nice. So we'll take two more questions.
Thank you for your inspiring talk. You mentioned community approaches and incorporating community voices into framing and shaping what we do for research. I wonder if you have become aware of any examples where community-based approaches have been successfully incorporated into healthcare systems. Are there any institutions, like very much traditional healthcare like ours, that have been able to create those bonds with the community to help them shape the kinds of questions and the kinds of projects that we'd like to undertake and co-create as well?
Yes, absolutely. I think there's a lot of different examples. Being an allergist, I'm going to use one that's a little bit more allergy focused, but for example, we work a lot with our community partners, like people like Food Allergy Canada, a lot of the parent and patient groups, and they've actually said, this is interesting. Some of the issues we're encountering. For example, it was talking about when you go to different places, could you look at it, is it safer to have EpiPens in the places versus the people carrying EpiPens? And that was really from a lot of our patients and our families. And then that led to a study that we did out of McMaster with Susan Wasserman, looking at what if we actually placed EpiPens in all the institutions that were selling any kind of food products, so all the restaurants, canteens, et cetera, and had them there, as well as, yes, obviously we encourage all our patients to still carry the EpiPens, but how does that work in terms of reducing, morbidity, mortality from food allergy by having them in these, similar to how you'd have a first aid kit or an AED present in all these different places. So that is actually kind of going from the other way. And so there is those opportunities. A lot of also sometimes you look at things in offices and, we say, oh, this is bulky for our patients. And so you have to actually do that more in the actual office settings, the community settings, to actually look at that, measure it, show, and then have the interventions. So there are definitely a lot of examples where you'll see the movement going both ways, and lots of opportunities. And ask, as a partner, say, is there opportunities to do this? So I think it's about just fostering the environment so that there is the ability to ask.
And I think we have one question. Yeah.
I just think that again, it's community related, and what you said about we have different cultures and different languages and all. So just wondering, what is OMA, or does OMA have anything in place with regards to our native Indian population in terms of their culture and they have their own languages also. So what is the aspect of research for that?
Yeah, so from the OMA perspective, we do quite a lot in terms of partnerships with our various Indigenous partners, in terms of other physician associations, in terms of also trying to make sure that we're providing support for any of the work that is being done there. But also within our leadership, we also do try to do a lot of training in terms of what is out there and in terms of who to work with in terms of further research there and supports, and making sure that we're giving our leaders within the organization lots of cultural competency, because that's what you really have to start with, and giving those kinds of skills so that you can interact with different populations in a culturally safe way, and realizing that you might want to do research, but understanding why this is not perhaps the way to go about it, and that you have to actually talk more with the community, go through elders, and understanding how you approach different communities and how to do it in a safe way for both ends, and really asking for what are the things that you're also interested in looking at to help with your community. And so we do that, and we help support our physicians to help have that kind of training, but also to have opportunities to link with our other I guess it wouldn't be community partners, but our kind of partner associations, whether it's our Indigenous physicians, whether it's Black physicians, different groups, and to talk about some of the work being done with different entities who have unfortunately had a lot of harms through medicine, and how we can partner to work to improve healthcare, but in a really culturally safe way, because that's really the key, not imposing what we think. That's never the way to approach any kind of community that has had harms from healthcare. You have to kind of go in, and you have to go in with humility, and you have to be able to recognize the harms that were done. And that's a lot of the training that we do in terms of that, especially for our leadership and our physician leaders, because culture starts at the top and then permeates through all of our physicians.
So we have we'll take one more question from our online participants. This question is from Yasser Khaled. He's our Director for Patient Experience. His question for you is, how do you balance research that shows improved patient outcomes and experience while challenging the status quo strongly held by physicians and clinical teams? Can you give an example of such initiative?
Thank you. I think what you're really talking about here is the change management. And so this is a big issue. Obviously, you can have lots of new innovation research showing better patient outcomes, but it really challenges the entire way that the entire team works. And so this can be quite different. So for example, when we talked about things like, I'll give you an example from my work in terms of vaccine allergy. I know nobody really wants to talk about vaccine allergy right now, but when we talked about some of how you look at it in terms of, people often felt very strongly for a long period of time, if there was any issues with vaccines, if there's any thoughts about allergy, that was just, no, that was, that kind of ended the conversation. They wouldn't get further vaccines. And so a lot of that actually was a lot of us doing some of the change management around that. And that required a lot of different thinking. Actually, having people say, you should actually refer those patients if they have had an adverse event, send them, because there actually are ways that we can safely vaccinate people. And I think that part was difficult because a lot of times they had just said, oh, they can't have this particular vaccine or they can't move forward. And so it really required us to do a lot of education with our referring physicians. We wanted to talk to those who actually are vaccinating. So talking a lot to our family doctors, also those in the hospitals, if they'd seen any reactions with vaccinating of the babies. It was used to be very much like end kind of stop there. And it was difficult because there is this kind of, we really want there to be safety. Isn't it safest just not to re-expose someone to something that's potentially dangerous? But I think it's a lot of it was explaining that our immune systems are actually very interesting. We talk a lot about memory, which is fair. And we talk about when you're vaccinated, we give you this memory to prevent you from having disease. But then people said, but here you are saying your immune reacted poorly and that maybe it's going to forget this part. How is there both this longevity of memory in the immune system, but you're saying it's going to forget that it had this bad reaction or had the immune system reacted poorly here? And so that is actually a huge difference in the way you think. And without getting too bogged down into words people are kind of glazed over, said that that's the beauty of our immune system, right? Is that it has the long-term memory and it does do that, but there's other parts of it that has short-term memories. And we actually also, and that's why we have to revaccinate. I said, well, let's talk about it. Why do we revaccinate each year then? It's because not all the memory is long. And so we're able to actually have those conversations. And it was a lot of kind of change management for people to start thinking, okay, if there's an adverse event, we'll still send them. There are possibilities, and then you can be safely vaccinated in whichever setting is best. But it did change a lot of that kind of thinking that, well, the immune system is going to remember this and we can't do it. And so I think that's where you have to break it down and really have more of those conversations and not necessarily talk about it super deep, because we could talk about it in a very deep immunological way with all the different cells. But it's actually just say, actually, our immune system just works in a lot of different ways. And there's times when there's parts of it that we really are depending on to have this long-term memory. And sometimes there's short-term memory and we actually utilize those parts. So those are the parts. And then having these conversations, but making sure that it's at the right level is where it was important. I think sometimes a lot of this can be conveyed, but it's not at the right level for how it affects each person's actual practice. So really say, okay, what is it at, for the teams and the different levels of teams? What's happening with the nursing, with the physicians, with the students? What is it that, when you think about this and the change, what is it that kind of gives you that initial hesitation, and address those issues too? Say, what is it that makes you hesitate here? And I think ask for that, because sometimes we assume we know why certain groups have concerns about some change management, but it may not actually be what you think. So actually address what their concern is versus what you think it is, and then go from there. And I think that's actually where you get some of the best change management, when you ask them what's causing them pause for change, and then addressing those issues.
Great. Well, thank you so much for your inspirational talk. And on behalf of Aura High, the Department of Medical Affairs and Quality, here's a small token from all of us for your experience. We're transitioning the slides. I'll introduce our next speaker. So to open our speaker sessions, we're pleased to welcome Professor Murtid Alfred from the University of Toronto, presenting on human factors in healthcare, supporting the quintuple aims. So about Dr. Alfred. She's an assistant professor in the Mechanical and Industrial Engineering Department at the University of Toronto, She directs the Safety, Equity, and Design Lab, which examines vulnerabilities in clinical systems that contribute to patient harm and embedded inequities which result in racial disparities in health outcomes. Her team also supports system redesign and quality improvement initiatives at local hospitals. Prior to joining U of T, she was a research assistant professor in the Department of Anesthesia and Perioperative Medicine at the Medical University of South Carolina, where she applied her expertise as a human factors engineer to improve the delivery of care through both research and practice. Dr. Alfred has published over 50 peer-reviewed articles, and her research has been funded by the Agency for Healthcare Research and Quality, Natural Sciences and Engineering Research Council, Canadian Foundation for Innovation, and CIHR, Canadian Institute for Health Research. She also holds appointments at the Unity Health Toronto and Michael Garron Hospital and serves as the editorial of several human factor journals. Dr. Alfred obtained her PhD from Clemson University in 2017. And on a personal note, Dr. Alfred has been working with us in our with our quality department to solve real problems that we're facing here at Osler. And that's where we're getting healthcare problems coupled with human factors and engineering minds, and we're doing some spectacular things. Most recently, Dr. Alfred has been appointed as Canada's Research Chair for Human Factors. Very intelligent, very humble, and we're so happy that she's here with us. Thank you.
Just gonna set my timer. Good morning, everyone. Thank you for the lovely introduction, Carissa, and thank you for the invitation. I also want to take a moment to thank my Uber driver. I was in the Uber this morning and I was seeing the time go up, and I was starting to get anxious, and I thought either I'm going to get there on time or I'm going to get in an accident with the way that he was driving, but he got me here safely. So thank you. I'm happy to be here this morning talking to this group about human factors, its role in supporting healthcare, and a bit about the work that I've been doing. And so, as Carissa mentioned, I'm currently an assistant professor in the Mechanical and Industrial Engineering Department at University of Toronto. I joined U of T in 2021, but prior to this role, I actually worked in a role that we consider an embedded research. I was in a hospital doing both research and supporting operations, first as a postdoctoral scholar and then as a research assistant professor. And so some of the examples of the projects that I'm going to share came from this experience, because I think that combination of research and practice is important, and being within the hospital is what allowed me to facilitate the translation of the work we did into practice. It wasn't always smooth, but we definitely have some wins. And so then I'll talk about that in relation to the work that we're doing here as well. But before that, I wanted to talk a bit about my education. And so I got my graduate degrees, both my master's and my PhD, in human factors from Clemson University. I was in the Department of Industrial Engineering. And Clemson, like U of T, the human factors program is within that department. I say this because human factors exists in psychology. There are computer science folks who do human factors related research, but I come from an engineering standpoint. And so in human factors, we're interested in the relationship between humans and how they interact with the system. And we're interested in this relationship in order to design and redesign systems that support safety, performance, satisfaction, and equity. I'll mention that I've added equity. In general, the first three were the bigger concerns of human factors practice, but I think particularly as human factors have continued to engage with healthcare in the last 25 to 35 years, equity has increased as a focus of our practice. And so I mentioned also that it's a scientific discipline. I think we've seen a bit of a tendency after we share our knowledge to say, oh, that seems like common sense, right? But it's based on our understanding and our study of how people learn, how people think, how people make decisions, how we remember, how we forget, how we work as teams, and how we communicate. So I'll do a couple of examples, and I'm glad that we're sort of in a smaller space. And so I recognize that this group is linguistically diverse, but I suspect that most of us can read the paragraph that's on the slide, right? It's filled with grammatical errors, but we can get through it. And that's because of a concept known as unitization. And this describes the fact that in alphabet systems, we tend to read the whole word and not the individual letters, right? And so this is why, and this supports our ability to read efficiently, right? Imagine how much slower reading would be if we actually looked at each letter before we read the word. But this also causes us to run into issues, right? And so this is why we have tools like spell check and grammar check, because we're used to thinking about the words as a whole, we sometimes misplace letters. And so that's why we understand that while this supports our ability to read, that it has this side effect of creating a lot of spelling errors. The other example I'm going to give you is around top-down and bottom-up processing. If I asked you what this image is, I'd get a few answers, right? Can I get some thoughts from the audience? What do we see?
It's the I, B, or 13.
It could be a B or 13, other symbols. But if I showed you this, then you would say it's a 13 because 12B14 doesn't make sense in most contexts, right? This is our top-down processing. We're using the context that's provided in order to make a judgment. Similarly, if I showed you it like this, you would have said it's a B. I've provided that additional context. So that's important when we're designing because it allows us to think, what are the mental models that our users are coming in with? Are we going to lead them towards a 13 or are we going to lead them towards a B? And it's also helpful just as humans because when we see, for example, a stop sign that's partially obstructed, we don't have to necessarily see it. We know the shape, we know the size, we know the color, and so we recognize that it's a stop sign, and then we're not confused and we know what to do. And so that's the background that we leverage when we're thinking about system design. And this understanding is very helpful in allowing us to not have to do research with everything we design. There are things that I can look at and say, this is a good design for this reason, or this is a bad design for that reason. And so interestingly enough, my PhD work was not in healthcare. I actually studied how we design virtual environments to support workforce training and education. My interest in healthcare started after I had already started my PhD. And it started with a Google search, as you can see. And that was the search I ran. My sister-in-law had cardiomyopathy. And I was interested after she gave birth or while she was pregnant with my niece. And I was interested in like most family members, I was interested in what this was. And so this sent me down a rabbit hole of understanding maternal mortality and the disparities in maternal mortality. And that led to my interest in the work that I actually do now. I wasn't able to start it when I landed my first position, but a lot of the work I do now is around maternal health and disparities in maternal health outcomes. And it started with this search. But after my PhD, I was fortunate to land a position, and these were few and far in between, as a postdoctoral scholar at the Medical University of South Carolina, in Charleston, South Carolina. And this is the role where I started to learn and do healthcare work. And so I was in the Department of Anesthesia and Perioperative Medicine, and my role was interesting in that I was mostly funded by research, but there was a small percentage of my time that was funded by the hospital to support operations. So in this role, I sat on a patient safety team. I consulted with our continuous improvement, which was our quality improvement team, also supported intraprofessional education. And so in addition to doing research, mostly in the perioperative space, I also went to weekly safety meetings. I attended root cause analysis and incident investigations. And so most of my work at this institution focused on patient safety. And that's because at the time, human factors in healthcare was still in its infancy. And the focus was largely on error reduction and patient safety. And when I say it was in its infancy, if you look at sort of the timeline of human factors, we started really in manufacturing, and our growth was focused around defense, aviation, manufacturing, as well as nuclear power generation. And so you'll see towards the bottom that it wasn't really until the 1990s that human factors professionals started to shift into the healthcare space. And the individuals, the researchers who were making this shift were folks who came out of those other high-risk organizations, and they were attempting to design models of errors in healthcare based on what they had learned in nuclear power generation and in aviation safety, for example. And so I also just wanted to quickly point out Lillian Gilbreth as sort of this huge figure in human factors, and just acknowledge that women have been supporting human factors really since its inception. But human factors in healthcare really picked up after the publishing of the To Err is Human report. And this was published by Institute of Medicine, now National Academy of Medicine. And what it pointed out was that healthcare is behind other high-risk industries in regards to safety. But what was most important, I think, for human factors professionals is this idea that system failures and not individual failures are the root cause of the challenges that we were seeing in healthcare with preventable deaths. And so after that, and in particular that decade that followed the report, we see a large increase in human factors research within healthcare. And so you'll see pretty sparse from the 1970s into the 2000s, but really the significant growth within the 2010s. And we can see some of the areas of research, a lot of work on medical device testing, and that continues to be a big area of human factors engagement, in addition to surgery, which is, again, a big area of human factors investigation. And so that early focus stayed on safety and errors, but the individuals, the human factors leads who were moving in this space started to recognize that our adoption of models, tools, and strategies from other industries had limitations. First, in how we think about errors, right? A lot of human factors work, the error models that were developed came from things like the 3 Mile incident, the Challenger disaster, and that's not how errors occur in healthcare, similarly with plane crashes. And so there was a recognition that we needed different models, but not just for how we think about errors, but also if you think about checklists and you think about crew resource management, Lean Six Sigma, all of these approaches that came from other industries, there was this thought that we would need to adapt them to healthcare because some of the systems that we were looking at, in particular when we think about manufacturing, it's a much less complex system in comparison to healthcare for a number of reasons. Healthcare is unpredictable, it's dynamic. Some of the challenges are emergent, and then healthcare has a lot of what we call clinical microsystems. The organization is a system itself, but then the ICU is a system, the OR is a system, the different wards represent individual systems. There are different teams within those systems. So there's a ton of complexity in healthcare that just doesn't exist in the domains where we adopted some of those tools. And so we start to see the development of models and tools specifically for healthcare. One that I lean on a lot is the Systems Engineering Initiative for Patient Safety. And so this is a model that built on the theory of socio-technical systems analysis, which says that when we're thinking about how we design and redesign systems, we have to think about the social components as well as the technical components. And when you're developing a system, you have to optimize these together. You can't just think about how the technology itself works. You have to think about the people who are going to use the technology, both upstream and downstream. You have to think about the environment where the technology is going to be used and how it's going to shape the use of the technology. And so we started to develop this model. And so this model has a few different iterations. The first in 2006, the second in 2013. There's been a update that sort of includes a temporal aspect for the patient journey that came out, I think, in 2019 as well. But this is one of the base models for human factors. And it's what I use in my work. And so I'll share a couple of projects we did. And I'll share these projects because there is a research aspect. They were generally funded. And I'm looking at all three. All of these were funded by the Agency for Healthcare Research and Quality. And with this work, we typically launch what we call a human factors or systems investigation. Then we try to use what we've learned in order to develop recommendations or interventions for improvement. And we use the SEEPS model as our backbone. The first project, and actually my first project in healthcare, when I was hired as a postdoc, there was funding allocated the initial project had funding allocated for a postdoc. So I was brought on to do work on surgical instrument reprocessing, which at the time didn't seem as exciting to me, but I actually loved this project. I enjoyed the work that we did on this project. And part of it stemmed from a clinical issue. My PI was sitting in a safety meeting where they were describing issues that they were having with their instrument reprocessing. It was leading to delays in first start cases. It was leading to some direct patient safety concerns. There were cases, for example, where the tray made it to the operating room and it had not been properly sterilized, right? So we have infection control issues there. And then other things like just broken equipment, missing equipment that impacts the efficiency of the surgical process. And so we did this huge human factors investigation. At the time, it was the most comprehensive investigation of surgical instrument reprocessing. Over 50 hours of observations, interviews with over 20 folks, both in sterile processing, within the OR as well. We developed process maps, we developed task analysis, and then we try to identify areas of improvement. We did come up with several recommendations. This was one of the projects where, because of turnover within the department at that time, we had, I think, 3 different leaders of the sterile processing department within 2 years. We weren't able to translate all of the findings that we described related to ergonomics, how the space is designed, flow, lighting, providing more knowledge in the world, trying to standardize the nomenclature of the instruments, which harder than it sounds, thinking about what we put in trays in the process for what trays we were going to do ultrasonic cleaning for, and in these really sort of low level or sort of at the front line concerns about which trays should be sterilized and how. I will say we did have one small win with this project, and it was related to a challenge we were having with how these retractors were assembled. Essentially, they were making it to the operating room assembled incorrectly. Now, as a human factors person, to me, this is clearly a design issue. The challenge is we can't force Baxter or Philips or Medtronic necessarily to redesign their surgical instruments. I will say with this project, we did ask them, we did make it clear to them that this was an issue. The fact that this retractor is disassembled into 3 parts just creates an error mode where it can potentially be assembled incorrectly. There are other models of retractors where this disassembly is not required. Their concern was that in the models where it's not fully disassembled, that not every part might be sterilized correctly. So small infection control concern that some folks say it's not high enough to justify not having the part together. And so we had an issue where there were multiple retractors incorrectly assembled in the tray. And it just so happens that it was one of those cases where the surgeon needed it, called for it, and now the scrub tech is having to disassemble and reassemble at a very inopportune time. And so we generated a suite of different interventions. And one of the nice, easy ones was really this visual cue that we provided. So we pulled the chest retractors out of circulation. We couldn't do color. There are sort of some concerns about actually having color, but we created an icon and etched it onto the retractors. And the goal of this is to provide a very quick visual cue that someone who's assembling it, if they see all of the icons on the same side, it was their representation that they had assembled it correctly. So a quick, simple human factors intervention, which is not always the case. And funny enough, we still ran into challenges with this, but there was enough support that we were able to move forward. Another project that I worked on related to anesthesia safety. This was a 4-year project funded by the Agency for Healthcare Quality and Research. And the goal of this project was to try to think about how anesthesiologists make errors in the operating room with the goal of designing ways to prevent them. And so we were thinking about whether or not the errors existed in the decision-making aspect of the process. Did you just, choose the incorrect drug, for example, or was it something more like a syringe swap? You chose the correct drug, and then somehow between making your decision and actually giving the patient the medication, there was a slip up. And so we spent a few years, and I worked on this project for 2 or 3 years before I then transitioned to U of T. So I worked on sort of the understand phase of this project, where we spent times doing observations, talking to anesthesiologists, talking to residents, talking to CRNAs about their processes, mapping out everything from pre-op to when the patient is sent to PACU, and understanding their process, understanding their workspace. So I'll share a few quotes from the folks who we interviewed, and these quotes came from different parts of the process. They're talking about what they're doing when they're setting up the room. They're talking about what they're doing during maintenance. And so in particular, there was a CRNA talking about how she prevents medication errors, including looking at the vial twice, labeling your syringe, checking it again before giving it to the patient. And so I don't expect you to read all of this, but I wanted to show you an example of how we try to make sense of what we're seeing. So this is an example of a functional, it's called FRAM. I'm forgetting what the acronym means, but it's a representation of how aspects of the work system. And so you'll see the SEEPS categories posted on the left, but a representation of how the aspects and elements of the work system interact to shape different outcomes. So this is sort of a very human factors development of how we analyze systems and relationship between components. For this project, we proposed a few different interventions. And so this one was interesting. Some of our students working in our biomedical engineering department, or the biomedical engineering department at Johns Hopkins, developed a medication storage tray. I left when this was being prototyped. I know there was sort of some back and forth about whether or not anesthesiologists actually wanted this. It seemed like some liked this, some weren't. I'm seeing some heads shaking about it. I don't know if I would want my medication stored in that way. the idea behind this one was around syringe swaps, because as you can imagine, sort of the way the medications are stored in that basin, it doesn't prevent syringe swaps. You can easily mix them up. So the idea is that if we have them sort of aligned, that you wouldn't necessarily make that mistake. The second intervention, which some of you would be familiar with, but we actually did get this intervention implemented within the hospital, was around designing icon-based labels for vasoactive medication. And this also stemmed from, this was related to the work, but also stemmed from an era in the operating room where the patient was given the wrong medication. And I think what was challenging about that particular case was that there was a handoff within the case. And so not one, but two anesthesiologists or anesthesia providers missed that the patient had the wrong medication. And some of this was just an operating room environment. It's dark. You don't necessarily see what's hanging. And so that was the thought around using a label that was just more salient. And so if you look at the pharmacy label, it's plain and it has the information that's required. But we wanted to do something that would highlight the type of medication and then provide anesthesiologists or anyone in the operating room with a quick thought in terms of what is being administered to the patient. And so we did implement this, and I had mentioned to the group, this was one of those interventions that we thought was pretty straightforward and would be easy to implement. And then it comes down to who's going to own the intervention, who's going to pay for the paper, and then who's going to print it, and then who's going to stick the actual new labels, because pharmacy, it makes sense. They wouldn't remove their label, and so this label would serve as a secondary label. And so we asked and they didn't want to be the ones to put the new label on the medication. So there were all of these little things that were impacting the actual implementation, but we were still able to get it set to a cost center, to get someone who was going to be responsible for making sure they were printed and posted on all of our vasoactive medications. And so this was a nice demonstration of actually managing the change, as the speaker before me mentioned. Generally, as human factors folks, we come up with the interventions and we sort of hand it off, but this was a case where we were forced to follow the actual implementation. And so I want to point out that some of the things that we did different besides the color coding was also the Tom and lettering, which is supposed to make it easier for providers to quickly recognize the type of medication using the unique aspect of the medication's name. And then the last project I'll discuss, I picked this one because I know Osler is in the middle of implementing robotic assisted surgery. And so I actually spoke to Sandra, colleague Tara Cohen, who was a co-PI on this work. We had a conversation where we shared some of our insights from this project. This was a 5-year project. Similarly, I supported the first 2 years. And this was interesting because this project had me in the operating room doing observations. I was one of the individuals collecting, one of the observers collecting flow disruptions. So I spent hours looking at urology procedure, gynecology procedures, gyn-onc procedures, as well as general surgeries. And so the idea of this project was to understand the integration of advanced technology in the operating room. And we use robotic assisted surgery as essentially a case study of advanced technology. So this was a 5-year study. It had 4 sites. The site I was at in South Carolina and 3 sites within California. For this project, we were collecting flow disruptions within the operating room related to robotic assisted surgeries. And so flow disruptions are essentially interruptions, hiccups in the procedure. And they essentially tell you how smooth the procedure is going. And when you see a lot of flow disruptions in the case, they highlight communication coordination issues and potential patient safety concerns. And so that was the idea around collecting this specific source of data. And so when I left the project, we were moving into the third year. And at that time, we had already started to notice when procedures went smoothly and when procedures had a number of challenges. And based on our findings, as well as findings from the literature, we were starting to come up with different interventions to support smooth robotic surgery. And so I shared some of these with Sandra around the operating room, the space, the operating room that the robot is placed in plays a big role in whether or not the case runs smoothly. Being prepared for challenges, troubleshooting malfunctions of the robot, having to convert to open, as well as allowing for a preoperative check-in. I think if I were to recommend sort of one insight that I think led to the smoothest surgeries, it was when the surgeon would show up just a few minutes before to actually check in with the team. I see head shaking, so folks are understanding that few minutes is worth a lot of operational efficiency. They get to check on the setup, make sure that they have the tools, they communicate any concerns or changes to the team, and then that allows the team to be proactive in terms of supporting the progression of the surgery. And so we came up with these proposed interventions. Some of these have been implemented. Interestingly enough, we ran into issues we weren't expecting, union-related issues, for example, in some of our hospitals, which said, nurses can't help with turnover, for example. That's the role of EVS. They absolutely cannot, they're not allowed to take out the trash. They're not allowed to do some of these things that might facilitate turnover of the operating room, right? And so all of these things important and interesting as we move from just providing recommendations to actually helping and supporting implementation. And so in parallel with the increase in human factors research was also efforts to integrate human factors as embedded professionals within hospitals. And that's something that we've seen over the past 25 years as well. And so I created a map just highlighting some of the places where I personally know human factors engineers who work as embedded professionals within hospitals. And so you'll see that it's mostly concentrated within North America. In Canada, for example, their human factors professional, there was for a long time at CHIO. She might have stepped away, but I saw that the position is open. So I expect CHIO will have a human factors professional. Sinai Health has a human factors team. UHN has healthcare human factors. Alberta Health Services also has a pretty sizable human factors team. North York General also. So within Canada, we are seeing embedded human factors professionals within healthcare systems. Some of them focus more on supporting operations. Some of them also support research. And so I provide a couple of examples. North York General and Healthcare Human Factors also support research in addition to operations. And then there are a number of hospitals within the US that has human factors research centers, including MUSC, where I came from, Cedars Sinai, who I worked with closely, and Hopkins, who I also worked with closely. And so even within embedded roles, human factors still work in and around safety and error reductions. But I think partially because of, and I'll say showing return on investment has been a challenge for our field, but there are folks who are working on it. Other literature has shown that human factors supports return on investment in terms of our improvements in usability and workspace design, but there are efforts to do this particularly in healthcare. So for the most part, the folks in human factors tend to work in and around patient safety, but also in simulations and clinical informatics as well. And so we do things like investigating adverse events, supporting technology integrations, redesigning workflows, improving physical ergonomics, supporting procurement processes, which is an area that I like to sort of try to encourage human factors to get involved with, because it has huge implications, and the equipment you buy lasts decades, right? And informing quality improvement efforts. And this is also directly related to the type of human factors investigations that have typically occurred in healthcare, where we're looking at injuries, layout, stress, workload, burnout, decision-making, teamwork, patient experience, patient and provider experience. But I will say, just in the last 8 years, I started this journey in 2017. In the last 8 years, we're seeing a big expansion of human factors. And in one case, I think the fact that the National Academy of Medicine invited a human factors professional to lead this report on burnout speaks to the growing influence of human factors in the space. That was Pascal Carrion, who was a lead in this report on burnout, and she's the original developer of the SEEPS model that I showed earlier. The other area of expansion is that I mentioned that human factors supports the quintuple aims, but I focus mostly on safety. Over the past 10 years in particular, there's been a push actually of doing what we call sort of putting the patient back into patient safety, and not only looking at what they do within the clinical systems, but trying to get a more holistic view on the work that patients do to support their care in and outside of healthcare system. And so we see different patient ergonomic models coming out, patient work models, acknowledging that in order to support patient experience, we have to look at both what's impacting the patient, both inside and outside of the clinical system. And this has sort of helped move human factors away from, I think, our focus on just clinical factors into actually having to think about social determinants of health and how it's impacting patients in their journeys. And so with these progression, we're seeing more and more human factors into areas where we haven't historically been. And this has been personally valuable to me, because when I started in 2017, equity and disparities was not an area of work that was necessarily seen as legitimate for human factors practitioners. And I think some of that just comes from the fact that for a long time we worked in very specific domains: military, nuclear, aviation. We were designing controls and displays, aspects that are where equity is less, equity within the design is less visible than what it is in healthcare. And so over the past couple of years, there's been a stronger push, particularly with the human factors professional working in healthcare, to do equity work and have it, push it within our field and have it accepted into our conferences so that we can share with the next generation of human factors students and professionals that this is an area of practice. And so we see books talking about human factors and social justice. And then I worked with some colleagues to talk about how we can support healthcare equity through human factors engineering. We've also seen a push towards different models of human factors integration within healthcare. And I'd be remiss not to acknowledge that the Advanced Practice Partnership, led by some very thoughtful leaders at Osler, including Tiziana, Carissa. I don't want to leave anyone out, but working closely with Kamal's team as well. We're seeing this push to not only have models focused on research or practice. I mentioned at MUSC, I had a unique position where I was funded through grants, but also had a small amount of funding through the hospital. And you typically see either or. Either you're fully funded by the hospital and you do operations work, or you're fully funded by research and you do research. And there's an unfortunate issue where the learnings don't meet. Even in places like Hopkins, which has embedded human factors individuals in human factors researchers, it doesn't necessarily translate. And so a model like this that's focused on how we integrate human factors within the healthcare system to facilitate the adoption of what we've learned over the past 25 years and continue to innovate, I think is really valuable, not just to me personally as a researcher who does human factors and is very interested in not just getting the publications, not just getting the grants, but actually translating this work to support patients and support providers. Having this opportunity is invaluable. I mean, I mentioned to the group that when I first arrived at U of T, this was a challenge for me, coming from an environment where I was in the hospital, where I sent an email and I went into the OR, I went to the scrub machine, got my scrubs, just sent a text, and that was my access. I was within. I could go into charts with the right permissions. I can get access to the event reporting data to do the type of research I wanted. Not having that was a challenge, and it was making me sort of rethink the type of research that I could do. I'm an assistant professor. I need to get tenure. I do need to get those publications, but I want to do good, valuable work. And so having a model like this, I think is valuable, not just for human factors professionals, but for the hospitals in terms of translating our findings and providing support for the capacity. The IHI talks about mentioned that quote I showed, every hospital needs a human factors or human factors expertise. We know that currently it's not enough human factors professionals to go around. And so the model of developing capacity within organizations is what's really going to support this idea of ensuring human factors expertise within different organizations. And so I'll end by sharing that human factors professionals are well positioned, and hopefully the presentation has shown, are well positioned to support the quintuple aims of healthcare, though we focus mostly, throughout our history, mostly focus on safety. But in addition to working closely with our clinical collaborators and healthcare professionals, hospitals also it would be beneficial to hospitals to also work to build that capacity. And through the partnership, I think we're demonstrating how that could be done. And then for my frontline folks within the audience, a couple of takeaways for you in terms of your work as you're thinking about how we design and redesign system. It seems straightforward, but when we say consider the user, we're talking about thinking about upstream and downstream impacts, thinking about how we make the work easy for the individual to do the right thing and hard for them to do the wrong thing. That's a core principle of human factors. Getting feedback, even through quick and dirty usability testing, is valuable whenever you develop an intervention. If you're designing a checklist, share it with a couple folks, get some feedback. Any feedback that you get is going to help you make that intervention stronger. I know literature searches are not the easiest, and depending on the access that you have, but it's always valuable to see what's out there. The issues that you're facing has probably been a challenge another hospital has faced. And so if you can see what they've done and copy that by all means, and then take advantage of the human factor specific resources that are available, including through the partnership, and that'll allow you to consult with with us. I didn't mention this, but as part of the partnership, we have a number of placements. There are students from U of T, engineering students in and around Osler supporting different processes. We have a postdoc who's now onboarded to support. Her main project is diagnostic imaging, but she's available to help with different challenges that come up. I'm around, as well as two other one graduate student and one recent grad. And so we're providing a wealth of human factors expertise within this space that's available to you. So I want to just acknowledge that the work I shared was funded by the Agency for Healthcare Research and Quality. Thank you to my collaborators at MUSC, Johns Hopkins, and Cedars-Sinai. And end with a quote by James Reasons, who developed the Swiss cheese model. We cannot change the human condition, but we can change the conditions under which humans work. And that'll probably be enough for supporting patient safety and the other aims of healthcare.
Dr. Alfred, you continue to inspire me and all of us each and every day, and we're truly, truly grateful for the partnership. So Martina's doing a lot of work with us. She mentioned a few of our postdoc students that are doing their placements. What she didn't mention is that tomorrow, we're actually building capacity for human factors, and that we're doing a pilot workshop on human factors with a few of our folks in practice, quality, and academics. It's a pilot. We're going to learn about principles of human factors. But what's even more important is that we're going to build faculty, and we're going to continue to offer this workshop at Osler on a regular basis, which will increase capacity for human design, human factors teaching, thinking at Osler, and that's all thanks to Dr. Alfred. Okay, so we probably have time for one question from the audience. Okay.
Thank you. That was a really great overview of what can be done with human factors. And as human factors sort of expand beyond the OR in these very specific spaces to getting more community involvement, to getting to involve a variety of professionals as well, I wonder if you have come across in the design of your projects any ethical concerns that arise. And the reason I ask is because I'm with the Research Ethics Office, and we are getting a couple of queries here and there about the students wanting to undertake the QI projects, but asking about ethical issues. How to address consent from the staff, consent from the patients, how to conduct the interviews in a respectful way. So I don't know if you could sort of highlight really, high-level concerns that may arise as you are designing your projects as well.
Yeah,
we can learn about them.
Yeah, thank you for the question. Yeah, I've come across a number of ethical concerns, and I'll say this is something I just think about as I'm doing my work. I think for students, all of my students go through ethical training, TCPS 2.0, in some cases city training as well. When I teach my students about how we work in clinical environments, respect for the patient and respect for the care providers is paramount. So for example, when they're doing observations, the key is to not be in the way. There are circumstances where the patient doesn't want you there, and so you leave, right? Even if you have permission to be in the operating room, you have permission to be in the space. We have to understand that this space is to provide care to the patients, and we don't want to make them uncomfortable. And as someone who's done observations, this is something that I've been mindful of as well, that there might be times where I'm doing an observation and I just shouldn't be in that space for a variety of reasons. So I will say we do think about that. So in addition to the research ethics training and trying to just tell students how to behave respectfully within those spaces, including the patients, which which might not be the focus. Some of our projects are QI, and so it's not the same, but making sure that they understand that. In terms of how I think about that in these projects, I do think about what it means to be in this space where you have ethical approval from everyone except the patient, right? I'm in an operating room watching robotic surgeries. I have the permission of the surgeon. I have the permission of the organization, but I'm in this space. You know, it's obvious patients feel uncomfortable. They feel very vulnerable, and you're extra eyes on them in this state. So it is something I think about. And then from the data aspect, there are conversations that you're probably privy to about sort of waivers of consent and that sort of thing that I wonder if I understand it and how we respect that it'll be valuable to improving care for everyone. But I will say I'm personally concerned about sort of blanket waivers of consent where we say, you've come to the hospital, if your data is in a EHR, then it'll be used by someone for some research. And so I don't think particularly as we think about AI and the use of this data to train models. So I don't think we've thought of it all the way through, but it is something I'm mindful of. When it comes to the observation work, I do acknowledge that getting consent for every single observation can become a bit taxing. And so I've sort of used it's obvious the patient is uncomfortable, they don't want you in the space, then we can do observations in another room on another day. So I don't think we have the answers. I think we're working through it.
Okay. Thanks so much, Dr. Alfred, again, for reminding us that achieving safe, more equitable, and patient-centered care depends not only on the processes and systems, but an understanding of the people that work within them. So thank you for inspiring us. I'd now like to pass it on to Como to kick off our next series of speakers with our quality improvement initiatives.
Good morning, everybody. So my name is Kumal Mazar. I'm the Director for Quality and Patient Safety here at Osler. So the next part of our agenda for today morning will focus on highlighting some of the great quality improvement initiatives happening within Osler by our own teams. These next set of 3 presentations will highlight projects that really began through Osler's internal QI Academy and have continued to evolve, really bringing a lasting impact from an improvement side around patient care, staff engagement, and system process improvement. So each presenter today will share how their initiative have grown since QI Academy and the impact in their respective areas. So our first QI Academy project really focuses on fostering safe, more compassionate environment for both patients and staff. So please welcome Wafa Chaudhry. She is the Clinical Services Manager for Mental Health and Addictions Program, and she will be presenting on trauma-informed care. Wafa oversees adult outpatient mental health program, corporate addiction services, including the Withdrawal Management Center here at Osler. And she's really dedicated to advancing trauma-informed care, recovery-oriented care across the continuum of mental health and addiction services. So I'll pass it to Wafa. Thank
you. Thank you very much. Thanks for that introduction, Komal. So as you mentioned, I'll be talking to you about how trauma-informed care has really helped us in the mental health space in reducing our code whites. And first off, I'd like to actually thank my director, Faiza Khalid Khan, who put my name forward last year to participate in the QI Academy course. And boy, what a journey that was. And although I'm the one here presenting, I'm one of 5 managers in mental health, and this is a program-wide initiative, not just focused on my area specifically. So I just want to start off by saying that. Okay, and so just briefly, I'll walk you through the problem and baseline data, why we started this project in the first place, what exactly is trauma and trauma-informed care, some of the QI methods we applied to this work, the interventions, data, results, and then the sustainability plan and next steps. Okay, so we noticed that in 2022 to 2023, in those calendar years that there was an increase in code whites. And for those of you in the room who may not know what that is, those are incidents of violence and aggression for which we need extra support and assistance to manage those scenarios. And so some of the common causes, when looking at the incident reports and reviewing those, is that the complexity of our patients was increasing, right? So we've got patients who are coming in with comorbidities, so multiple diagnoses, concurrent disorders, mental health and addictions related concerns, and then couple that with, post-pandemic staffing related shortages and all of those things, delays in certain treatments, and obviously behavioral escalations depending on, if needs are not met, et cetera. And so at the time, the existing approach was really emphasizing on that containment and that crisis management. And what that really means is, although we have policies and procedures in place to use seclusion and restraint, if you can imagine, right, you're having this problem, you're dealing with it by now kind of containing and using seclusion restraints among other things. And although it may be indicated, that can lead to further conflict and further re-traumatize our patients. And so consequently, that can also then lead to delays in the recovery goals that our patients have. So briefly, what exactly is trauma? Trauma is considered an invisible wound. So think about it as, somebody may have experienced an adverse event in their life at any point, whether it's abuse, neglect, war, domestic violence, severe bullying, financial concerns. It's not an exhaustive list, but these situations and experiences can leave potentially long-lasting effects on an individual's ability to cope mentally, emotionally, physically, behaviorally, and even spiritually. And so that can affect how they then access care, the type of care that they receive, and then how they actually respond to some of the treatment. So there's a growing movement with applying trauma-informed care frameworks in a variety of different sectors. So school systems, a lot of workplaces, as well as now healthcare. And this philosophy or this paradigm really, it assumes that anyone that walks in through our door may have a history of trauma. And, this individual may or may not disclose it, and they don't have to for the purpose of receiving care. And so this framework, this trauma-informed care framework, really fosters what we call the sense of safety. So think about it. When you go to your doctor, you want your doctor to look at you, not looking at their computer screen when they're trying to talk, when you're trying to tell them your problem scenarios, they're back faced. So this is sort of that idea of creating that sense of safety, that you're hearing your patient, you're creating a safe environment, you're hearing kind of what their concerns are. And in terms of promoting awareness, we're actually looking at, incorporating trauma-informed care into our day-to-day work. This is a philosophy, as I mentioned, and we're looking at incorporating it into our policies and procedures. With trauma-informed care, we also want to be able to collaborate with our patients, provide choice, be able to highlight our individual strengths, right? Their resiliency. It takes courage and vulnerability to seek help for some of the things that they're here for. And then more importantly, it's this shifting of attitudes, right? We're going from this kind of judgmental, if you see somebody who's maybe having a behavioral escalation and you kind of, what's wrong with them? To this idea of curiosity. Oh, I see that you're in distress. Can I support you in any way? Do you need something right now? Right? So it's that shift from that judgment to that curiosity, from what's wrong with you to let's talk about what happened. So we don't all have to be trauma experts to practice in a trauma-informed way. Anyone can apply this framework. And so as a part of this project, our goal was really to look at the reduction of code whites in the mental health program and reduce them by about 25%. So I'll share some data in a moment, but from 305 code whites per calendar year to about 228 in a 12-month period. I know that's a bit ambitious, but ultimately the underlying goal is to create a safer, more supportive environment for both our patients and our staff. So here's our baseline data. It's our number of actual code whites in the mental health program across the different units. So you can see the dark blue is 2022, light blue is 2023 with the different units underneath. And as you can see, the trend that is happening is all of the different areas are showing an increase in the code whites across the different spaces, with a particular focus on our mental health intensive unit, our Gen C, which is the unit where we serve patients with psychosis and schizophrenia, and then our child and adolescent unit. And so as a part of the QI course, we did a root cause analysis using the Ishikawa diagram, and otherwise known as the fishbone diagram. And we looked at a lot of the different factors that were contributing to those increase in code whites. So as I mentioned, we looked at the patient factors, right? The comorbid, concurrent conditions, the complexity was increasing. There's a history of trauma that, we're noticing. Also the environmental factors, inpatient settings, outpatient settings, sterile environments, loud noises, hustle and bustle, chaos. And there's just, in some ways, limited activity on the units, or limited therapeutic activity, I should say, causing a lot of kind of boredom in some cases, or not enough things to do while they're getting their treatment. The staffing factors, I mentioned post-pandemic era, recouping the staffing losses that we had, high turnover rates, the more seasoned team, leaving, and then the newer teams joining. So having to train and upskill all of the new folks. Policies, training, and education. We didn't have a trauma-informed care policy or it embedded into our frameworks. And so looking at kind of, what are the ways in which we can help support this project that we're doing. And so when you take that fishbone diagram and you flip it on its head, you get a driver's diagram. And this is kind of, on the one hand, you're looking at all the causal, reasons for kind of the increase in code whites. And with the driver diagram, you're looking forward to what those change ideas might be in relation to how you are going to achieve your goal. So as a reminder, our goal was to reduce our code whites by about 25% within a 12-month period. So how are we going to do that? Right, our primary drivers are the staff capacity and capability. Do they feel equipped? And I'm sorry, it's a very fine print, so I don't expect everybody to read this. But looking at the environment that we have across our mental health program, looking at engaging our patients, right? And then embedding our policies, procedures, and training. And so I'm going to skip over kind of the secondary drivers and kind of jump right into the change ideas. And they're in no particular order, so I'm just going to kind of share. We started a safety subcommittee where we met monthly to review our code white data, among other data sets, to look at kind of the trends that were occurring or are occurring in our mental health program. We incorporated trauma-informed care into our management of aggressive behavior training. This is a training we provide all staff with when they're joining our mental health program, and then we recertify them yearly or every other year, depending on when their certification expires. And then we also embedded trauma-informed care principles into the new hire orientation. In addition to that, we also paired up our outpatient staff with skilled psychotherapy expertise to train our inpatient team members on some of the skillful ways to approach different scenarios and conversations to help equip them in ways of de-escalating. So we wanted to really focus on those proactive measures to contain situations rather than those reactive kind of containment and crisis management type of approaches. Another initiative that I wanted to highlight is Safe Wards, which is an evidence-based framework to improve the therapeutic milieu and the environment of our different mental health areas. So these are different interventions that we apply to create a more safer space, which is, again, trauma-informed. And a part of that, I'll share a picture of this in a moment, but looking at creating therapeutic spaces, we actually created one on the CHAD unit, which is our child and adolescent, a sensory room on that unit. We also developed evidence-based or pulled together tools that support staff in conducting conversations, creating safety plans, ensuring that they have the tools to have these difficult conversations, and then increasing our unit-specific meaningful activity so that patients have a lot of activity and things to do while they're in treatment on the units. In addition to that, we worked on creating a trauma-informed care learning module so that all our staff, even if they aren't able to attend a training, they can get that education and knowledge from that learning module. And then another initiative that was really critical is that we wanted our patients' voice and engagement to be embedded within our program. We restarted our mental health patient family advisory council. We know we have a corporate one at Osler, but we wanted a specific one in mental health so that we could get that specific feedback related to our program. So measurement plan, of course, the obvious one is that outcome measure is the number of code whites going down with all of these interventions. Along with that, we also have to look at some of the process measures, how many staff are actually completing the new hire training, how many of them are going through the MOAB training, how many of them are participating in the therapeutic skills. And in the future, we're also going to add the number of staff completing the trauma-informed care learning module. And then also when you're looking at kind of the outcome measures, you're looking at the measurements along the way, the process measures, you also have to look at, if I'm making all these changes and I'm affecting this one area of the system, what else am I impacting? So on the one hand, right, yes, the numbers of code whites are going down, but is that negatively or positively impacting other areas? So for example, seclusion and restraint use, of course, we don't want that number to go up. We want that to also come down. But in addition to that, it's great that we're embedding all these things within our staffing perspectives, but what are the client's actual experiences? What are, so collecting their perspectives from evidence-based surveys. So now we're also partnering with Patient Experience to roll out evidence-based survey collection across our mental health department so that we have comparable data to others who are also completing those. And of course, no QI project is complete without PDSA cycles. So the Plan, Do, Study, Act. In our first PDSA cycle, we implemented a lot of the, as I mentioned, the trauma-informed care principles into our training, new hire training, MOAB training, and then the skills training. And we also launched or created some environmental changes within different units, for example, CHAD. In the future, we're going to be doing a second PDSA cycle, and I'll share more of that later. And that's really around when we roll out the trauma-informed care learning module. And really, the learnings are that staff want that concrete information. They want to be able to have certain tools to apply it and put things into practice. It's great that we say, do this and say this, but how do we actually do and say that? And how do we actually respond to these situations? And so these are the images from the sensory rooms. I just want to give a shout out to Simranjeet. Thank you so much for providing me these. And so on the left, we have two sensory rooms on the child and adolescent unit. One is on the inpatient side, and one is on the adolescent intensive day program. And this is really a space to help our adolescent clients have a space where they can go and regulate their emotions, feel, when they're having outbursts or if they're going through some kind of situation, this is a place for them to be able to kind of focus and take that time. Funny story about this room. So last year, the manager who was responsible for this area, around this time, we were setting this room up. She went and purchased all the supplies that are required. So all the different sensory tools, toys, lamps, and all the different equipment that goes in this room. And she used our mental health corporate credit card that we have. And so a couple of weeks later, finance calls our director, and they're shocked. They're like, okay, we've got a staff who's gone rogue. They've done all their Christmas shopping on your credit card. Do you know about this? And so all purchases can be accounted for, as you can see. And yeah, so just an evidence, and there's a lot of research actually that's coming out to support the use of sensory rooms. And actually Simranjeet, one of our resource nurses, has been selected to complete a fellowship for the E-Inspire program to test out the efficacy of a space like this. So looking forward to the results of that. Okay, so I shared this similar graph or chart earlier, and now just the only addition here is we've put in 2024 data. Of course, we haven't gotten to the end of 2025 yet, but as you can see, you know, everything else was going in the red before, and now thankfully, with some of the interventions and the PDSA cycles that I mentioned, our code whites are coming down. And more notably, you can see in the Gen C unit, you know, where we've implemented some of those safe wards initiatives, and the CHAD unit, the sensory room, and then also in our outpatient areas, there's a significant decline in code whites. We didn't hit the 25% mark, 22%, but you know, pretty close. But that's the work of QI. You implement, you refine as you go, and then you keep assessing what else needs to be done in that. So next steps in terms of our sustainability plan, of course, as I mentioned, we're going to review our 2025 code white data. We are going to be launching the mental health specific trauma-informed care learning modules. From that, we review our data at our safety subcommittee, which we're going to continue doing to maintain the momentum that we've generated through this program. And then, of course, you know, continue with the PDSA cycles. As I mentioned, those don't end when your project does. We got to keep going, because this is not just an initiative. This is embedded into our day-to-day work. And yeah, and so that's the end of my presentation. And thank you.
Congratulations, Wafa, to yourself and your team on
Thank
amazing improvement. Any questions from the audience? Okay, thank you so very much for your talk. I will have Nimra, our manager for quality and patient safety, introduce the next set of speakers. So over to you, Nimra.
Thank you, Komal, and good morning, everyone. So our next QI Academy project shifts attention to evidence-based skincare and harm prevention. For that, I would like to invite Carla Arpa, who is our assistant manager in the medicine program. Carla has around 25 years of experience in acute medicine and surgical care, and she's really passionate about advancing quality initiatives and optimizing nursing workflows to enhance patient care. Carla's talk today will focus on her work to reduce incontinence-associated dermatitis and pressure injuries through evidence-based skincare. Thank you for being here this morning, Carla.
So much. Needs. Okay, thanks everyone. So mine is healing from the bottom up. It's a multi-site initiative to reduce incontinence-associated dermatitis and pressure injuries through evidence-based skincare. So how this kind of journey started for me in QI was when I did the IIWCC, which is a certification in wound care. And I've been working as an educator in respirology. And I started in 2020 during COVID, you know, best times. And I was observing, you know, what were the staff doing? And after taking that course, I really started to see those gaps in practice, in education, acknowledging even my gaps myself, but in nurses overall, that there wasn't a lot of education for wounds, pressure injuries in education in nursing. And then you really see it on the front lines. And then during COVID, of course, we had supply chain inconsistencies and a lot of very personal practices. And so knowing that incontinence-associated dermatitis leads to pressure injuries, it really was important that we do preventative, right? Like, let's prevent pressure injuries, because once they occur, it's really hard to manage. And so this kind of all started my thinking. And so then I had the opportunity to do the RNAO Advanced Clinical Practice Fellowship. And it's through that where I began kind of my QI journey. and started to identify some research. And I found an international incontinence-associated dermatitis best practice guideline. And during that ACPF, if anyone's ever done it, it's quite a long, intensive project with research and a whole application. And so it's very thorough. And so part of my learnings in there was to do research and to do a pilot and to standardize the practice. It took a year to complete the ACPF, and I did complete it in January 2023. The pilot occurred during October 2023 to December 2023, so 3 months. And I had submitted all of the information to the RNAO. So the research shows that combining products makes it easier. So this is the human factors. Actually, listening to human factors was like, oh my God, I'm applying human factors. This is amazing. Because if you make it easier, then staff are going to do it, right? And so that's what the literature shows. A 3-in-1 product does that. It combines all the steps and makes it easier for them. And our previous process was quite involved. There was sprays and creams and wipes, and so they had to bring everything in the room, and then they had to use it and apply it. Where the new system was all combined, and so then it made it easier. And during this as well, I started to notice not only were there inconsistency in practices, but sometimes if something's going to take too long, it's not going to happen either, right? So now we're in a busy time. We were in COVID or even post-COVID and staffing issues and very sick patients. And so bathing kind of fell off of the priority list, and inconsistencies continued. You didn't even see it at the bedside anymore. So the prepackaged system just offered, it cleans and it moisturizes, a step that's frequently not occurring. We don't, moisturize our patients, unfortunately, anymore. And then it was warm. It comes in 8 wipes for the bathing, so each for an area of the body, so there's no cross-contamination, so nice and easy. And then the Shield, which is the incontinence care product, it cleans, restores, and protects all in one. So now the skin is actually all getting a preventative measure and protection. So this is some of the data from the pilot that occurred in October during that time. And so if you see the incontinent rates, so the blue line is the percentage of incontinent patients. So I wanted to look at that because I just didn't want to say, well, the IAD went down because maybe there was no incontinent patients, right? And so you have to make sure we have incontinent patient. And
North Building, 4th level, room 475, flow stream rehab. Code blue, North Building, 4th level, room 476, slow rehab.
So the incontinence rate was consistent with the literature. It's in an acute care facility, it sits around 40 to 60%. So that was evident on the Brampton Respirology unit. And then the incontinent rate started at 54% at the beginning of this pre-implementation. And then post-implementation, it went down to 17%. So that was an overall 74% reduction in IAD. It reduced bathing time by 12 minutes per staff per bath. So that was a huge incentive for nurses. If it's going to, happen faster and make your day easier, you're going to do it. We also increased the documentation and identification of incontinence-associated dermatitis and pressure injuries because of all the education we provided prior to the implementation. And the staff were 100% satisfied with this new product, right? You like it, you're going to use it. And so that caused them to standardize the practice because they liked it. Now everybody was doing the same thing. Okay, so that brought me then to the QI journey, where I got to learn so much more about QI initiatives that I didn't even know, right? Like I didn't know the stuff I didn't know. So now I got to learn all of the methodologies and all of the thinking behind all of QI initiatives, which was an amazing opportunity. And knowing that I did this pilot, I wanted to be able to now share it with all of the other units to have that same success. So that's where it came from. Of course, you're looking at the same outcome measures that I did during the pilot, but now it was bringing in more key partner involvement, using the tools like the fishbone. And so this is what I say, it like kind of filled my backpack with all these new tools that I'm going to continue to use in my career. At this point during the QI project, the next steps at that time were through the PESC committee for approval, doing ADCAR to help facilitate the change corporate-wide, and the planning to start implementation, multi-site. Okay, so one of the tools you learn is about your Gantt chart. So got to make this one and really plot out how I was going to implement multi-site between Brampton and Etobicoke. And I split it up into 3 phases. The first phase being Brampton. This was across all medicine and surgical departments. And then phase 2 was Etobicoke. And then 3 were kind of like outlier areas that we weren't sure if it was a right fit for those areas. And so we've plotted out, it started in July of 2025. So Brampton Medicine Surgery has been implemented. September 2025, we did Etobicoke, and that's all been implemented as well. Some of the challenges, Brampton actually was a bit of a smoother transition. Etobicoke a little bit more challenges just because of space. So finding space to put that warmer and all of the supplies, the JIC cart, so forth, made it a bit more challenging. But we were going through accreditation right at that September mark. So, you know, I'm grateful to all the managers who were really great and helping to facilitate the implementation, even though they had some other priorities. So, all right. So this is kind of where we are now. Like I said, Brampton is implemented and Etobicoke. We've collected pre-data. So again, looking at those IAD rates and practices of the nurses. And then we're now looking at RCU. So that is in process. And then come the winter 2026, it's all of the data collection for Brampton and Etobicoke, looking again to compare post-implementation. Here's a little sneak peek of some of the data that's been collected so far. So like I mentioned, the method that used for data collection is nurse surveys. They're in person, and of course, environmental assessments of supplies and practices. Questions asked on IAD prevention, when barrier cream is used, which products are used, moisturizers, if they're applied, and if their practice is consistent every time. Other data collected is the number of incontinent patients, the immobility status, the barrier cream present in the room, the number of patients that do not have barrier cream, and the number of patients who have IAD. So pre-implementation IAD for Brampton is 41% and Etobicoke is 32%. And so for of the nurses surveyed, 79.37% put that barrier cream once redness occurred. So we already know that's a little late, right? We want to do it preventative. So we want to change that practice. 71% moisturizer only done PRN. And 93% say they don't use the same products every time. So hoping to see better consistency and standardization after implementation. So, okay, so what's kind of left in the implementation stages? So the Brampton Emerge actually did not get implemented as part of that phase 1 because they were under construction. So still exploring getting that started, and that's in the works. Mental health, looking at implementing there in appropriate units that they feel there is a need. And then the last is that NICU and pediatric population. Still exploring that opportunity, knowing that it is actually scientifically safe in the pediatric population, but we're not quite sure about the NICU, but there is a need. So more discussions to come to see if this is something that would be helpful for them. All right, so what I plan to continue to do is get that post-data collection. I hope to disseminate these in conferences in future and hopefully a future manuscript of all of the data. So I wanted to really thank ULSR for providing so many opportunities to learn and grow, especially through these quality improvement initiatives and programs such as the ACPF and the QI Academy. These experiences were the foundation of my journey in improving patient safety. Along the way, I've also learned that quality improvement is the practice of imperfect people guiding other imperfect people to achieve extraordinary things. And I've learned that courage isn't about feeling confident. It's about feeling terrified and doing it anyway. And that's the only kind of courage that truly matters. So if you're thinking of something, anything, that can make patients and staff safer, I encourage you to do it and do it now. Your idea might be the one that makes the real difference. Thanks.
Thank you, Carla. Any questions for Carla? Yes. Sure. Go ahead, Laura.
Thank you, Mark. Congratulations on being with the RMU. My question is around the process measures. So I see survey to capture whether or not the interventions are being implemented. I'm wondering what led you to the survey rather than charts and how surveys may affect sustainability.
Yeah, so unfortunately, charts, especially in our current Meditech system, are just not a reliable data source. So already there was a gap where staff were not charting IAD to begin with. So I wouldn't find it. We did, during the pilot, add that as part of the wound charting as an IAD, but without the education and implementation, still staff are not, they don't know how to identify it, and they definitely weren't going to document it. So unfortunately, it's a tougher way because it's like a lot of manpower to go around asking every nurse on a shift about their patient to get the data, but our system just doesn't have the capability to collect it right now. Thanks.
So the data that you generated says respirology for both etopical and events.
So the Etobicoke and Brampton data is for all medicine and surgery.
All medicine.
Yeah. So the pilot was at Brampton, but then the new implementation was all of both sites.
You just said something about the staff not being able to identify. I was just going to bring that up. And identification of the wound is one thing. The second is aggressive. So, yeah, I'm just seeing that. I came from it also. You're right. I'm just noticing this. Wondering if you don't have that.
Well, I think this is a baby step in that direction, is that it's provided that little bit more education, understanding of preventative measures as we're growing the knowledge of nurses for wounds and wound care. And hopefully the goal is to prevent them. So then that knowledge is not so important anymore because we've prevented most of them, right?
Did you get any patient experience feedback on the products?
Yeah, so that was a challenge I tried in the pilot. The problem I discovered is that patients don't really understand, or there was a lot of cognitive impairment, because again, you're at the incontinent patient. So either there was cognitive impairment, language barriers, or they didn't even understand the products. Or I tried to reach family, which is very difficult because they're not always there when I was there, you know, my 8 to 4 shift. So I found that was really a large challenge to kind of collect that data. But I thought of it because I thought it would be a great piece to capture in this, to see like what was their perspective of it. From what I hear from nurses is that patients like it. So I did get that kind of feedback, but I didn't actually get to collect data because it was a lot of manpower for that one.
Yeah. For sure. Thank you.
Great. Okay, thank you.
Okay, so up next is our last QI Academy presentation, which focuses on enhancing patient flow and supporting smoother care transitions. Please welcome Tarndeep Banga, who is the manager for medicine program. He has a background in diagnostic imaging and leadership with a strong focus on patient care and operational efficiency. Welcome, Tarndeep.
Hey, good morning, everyone, and happy Research Week. Sorry, I have a bit of a head cold, but I'm going to try my best to get through this. I didn't want to miss out on this discussion today. So my name is Tarndeep Banga. I'm the Intern Clinical Services Manager for the General Medicine Program at Etobicoke General Hospital. Thank you for having me today, and today I'll be sharing our QI project focused on enhancing early inpatient discharges. So being relatively new to the general medicine program, I did notice that our clinical teams are facing ongoing challenges with patient flow and late-day discharges. And this QI project became our way of looking at that issue differently and focusing on team-driven changes that could make a real impact for both our patients and staff members. I'm hopeful through this work that we can continue to improve patient flow, support staff workload, and enhance the overall patient experience. First off, I have no disclosures or conflicts of interest to declare. In this presentation, I'll be sharing some background on the project, outlining our key objectives, and walking through what we did and we found, and wrapping up with some updates, next steps, and the overall impact of our work. Like many medicine units, we've noticed that late-day discharges are a common challenge, and this can create a domino effect across the hospital. Backlogs in the emergency department, delayed admissions for new patients, and increased pressure on staff and resources. Timely discharges are important in maintaining efficient hospital flow. And when discharges are delayed, it often results in slower bed turnaround, increased length of stay, and reduced capacity for both incoming admissions. And we all know that earlier discharges benefit both patients and their family members as well. It reduces wait times, it supports smoother transitions home, and improves the overall patient experience and satisfaction. On our unit, we had a sense that discharges before 11 a.m. were not happening often, and this was an important opportunity for improvement. So data plays a big role in shaping our framework for change and ensuring our efforts are based on evidence rather than assumptions. So to start, we collected baseline data over a 6-month period on our unit to understand current discharge patterns. When we reviewed the data, a clear trend emerged that the majority of discharges occurred between 2 p.m. and 5 p.m., and a significant portion even later, after 5 p.m. Only 8% of the discharges occurred before 11 a.m., which confirmed what we had anecdotally, that early discharges were not common, and there was a clear opportunity to improve. On this bar graph, you can see how most patients are discharged within 6 hours of the discharge order being written. So this tells us that once a discharge decision is made, the process moves fairly quickly, but the timing of that decision tends to be later in the day. And this data helped us pinpoint to where to focus our improvement efforts, not just on efficiency after the discharge order, but on earlier decision-making, communication, and planning throughout the patient stay. So now that we have a clear understanding of our current state, we are ready to define our QI project objectives. So our goal was simple, measurable, and time-bound. To increase the proportion of early discharges, those occurring before 11 a.m. on AD's medicine by 10 to 15% by the end of March 2026. And this goal directly aligns with our hospital's broader initiatives through the executive patient safety rounds and supports Osler's commitment to improving patient flow and experience. Ultimately, achieving early discharges does not just improve efficiency, it also enhances patient experience by promoting smoother transitions of care. So with our project aim established, our next step was to understand why late discharges were happening in our unit. So we conducted a survey with 28 staff members, which gave us valuable frontline insight. And what we learned was that discharge planning often began too late in the day. typically in the afternoon. And in addition, communication about discharges readiness was not always consistent between team members, which led to delays in decision-making and coordination. We also recognize some limitations with our data collection, and that is mainly due to some legacy issues with our current hospital information system, that the order entry times may not always be captured accurately. And this could explain why our data showed many discharges occurring within 1 hour of the order being written, when in reality, the discharges probably took a lot longer. To explore these challenges further, we huddled with the staff and held several brainstorming sessions to identify barriers and potential solutions. A few key themes emerged. First, limited early identification of discharge-ready patients, and second, gaps in communication among the team members. These factors contributed to the consistent pattern of late-day discharges that we were seeing across the unit. Here's a copy of the staff survey that we used to help validate and guide our decision-making. We wanted to hear directly from our frontline team about what they saw as the main barriers to early discharge and what they felt improvements could be made. The survey results provided valuable insights into staff perspectives and helped confirm that our chosen areas of focus, communication, discharge readiness, and standardized processes were aligned with the team's experiences and priorities. So as part of our quality improvement process, we used 2 key QI tools, a driver diagram and gamma walks, to further understand our current state and identify where to focus our efforts. So a diver diagram, as shown here, is a visual tool that helps map out the factors influencing our project aim. So it starts with our project aim statement, in this case, improving early inpatient discharges before 11 a.m. And from there, we identify primary drivers, which are the major areas that directly impact our goal. For us, these were patient rounding, nurse to physician communication, and discharge criteria. Each of these primary drivers connects to secondary drivers, which are specific processes or behaviors that either help or hinder progress in those areas. So for example, under communication, we noted inconsistency on how and when discharge plans were discussed between disciplines. And under discharge criteria, we found that staff had various understandings of when a patient is actually discharge ready. So mapping this out visually helped the team to see the system as a whole and pinpoint where targeted changes could make the biggest difference. In parallel, we conducted gamma walks, which means going out to the unit to see where the work is being done. So we went there to observe, ask questions, and learn from the staff directly. This allowed us to see real-time barriers to early discharges, such as delays in decision-making or communication gaps during routes. Combining insights from the driver diagram and the gamma walks, we narrowed our focus on 2 key change areas that we felt would have the greatest impact. First, to educate staff on discharge readiness and building that awareness on how early planning can help improve patient flow and overall efficiency. And second was to utilize a standard discharge checklist to promote consistency and ensure all necessary steps are completed in a timely and coordinated way. These tools did not just help us come up with ideas, they actually helped us see the system differently and identify root causes of delays and move towards meaningful, team-driven approach. So we are very fortunate to receive external funding through professional practice, which allowed us to endorse one of our point-of-care nurses, Zawa, to continue this quality improvement work for the e-Inspire initiative. Within this capacity, I've been mentoring and supporting Zawa throughout the project. This approach has been incredibly valuable because it helped ensure that the work was driven by the front line, by someone who truly understands the day-to-day realities of patient care on AD's medicine. Having a peer champion like Zawa helped build staff buy-in and trust in the process. Team members felt heard, represented, and reassured that their perspectives were being incorporated into the project. And I think this sense of ownership among the staff has been one of our greatest strengths in this initiative. Staff buy-in is really at the heart of any successful QI project. When people feel that change is being done with them rather towards them, they are much more likely to engage, offer ideas, and sustain improvements over time. So as part of our next phase, Zawa and I conducted a literature review to explore best practices and identify proven strategies to support early discharge. One article that really stood out to us was by Di Maio and others, published in the Joint Commission Journal on Quality and Patient Safety this year. In their study, the team at Hale New Haven Hospital faced challenges very similar to ours: late discharges, limited bed availability, and admission bottlenecks. To address this, they implemented a Propel discharge checklist, which helps standardize the discharge process and promote earlier planning. The results were really impressive. The pre-11 a.m. discharges increased from 5% to 22% across 447 adult medicine beds, which represents about a 15% improvement. And this finding really reinforced that structured discharge planning tools can have a measurable impact on patient flow and overall efficiency. It also validated that our change ideas, education on discharge readiness, and implementing a checklist are evidence-based and are aligned with successful practices elsewhere. So here's a draft copy of our Propel discharge checklist. This was developed in consultation with our leaders, nurses, discharge planners. We're currently finalizing the checklist and plan to roll it out in December, following additional staffing, education, and review to make sure that everyone understands the project goals and their role for this project. Our plan is to integrate the checklist into our morning bullet rounds and using it as a standardized tool to help guide discussions around discharge criteria and readiness. Our resource nurse or team lead will complete the checklist using a paper format of clearing the rounds and marking out all the relevant points for each patient. And by collecting and reviewing these checklists up until the end of March 2026, we aim to compare the results against our baseline data and evaluate if this approach has led to an increase in pre-11 a.m. discharges. If we can demonstrate a positive impact, our goal is to incorporate this checklist electronically into the bullet rounds application, allowing for easier access and data tracking. Ultimately, this could support broader adoption across all medicine units at Osler, helping to create a consistent, evidence-informed approach to discharge planning system-wide. So this brings us to how we're evaluating our QI work. Since this project is still ongoing, we'll soon start by trialing our change ideas on the AD's medicine unit using small change iterative approach, PD-SA cycle, plans that do study act. So our first step is focused on improving morning discharge discussions with the interdisciplinary team and to ensure early identification of discharge-ready patients using the Propel checklist. This stepwise approach is key and will allow the team to adapt, reflect, and build confidence in each change before moving forward, ensuring that there is progress without overwhelming the staff or disrupting clinical workflow. And through continued PD-SA testing, we'll be able to study our results and make amendments as needed, refining our processes based on what we learn to ensure that the changes are effective and sustainable. So in summary, I would say one key learning from this project is that communication truly drives change. When everyone from nurses to physicians to allied health have a common goal and discuss discharges early, the process flows much more smoothly. Celebrating small wins along the way has also been crucial for maintaining momentum and team engagement. Looking ahead, our focus will be on sustaining these improvements by embedding the process into daily routines. We'll continue to monitor data monthly and provide regular feedback, and also explore EMR-based alerts to flag potential early discharges. Ultimately, our long-term goal is to share these lessons across other units, medicine units, and spread their practice to have been proven effective. So I would like to thank a few people who made this project possible. First, a sincere thank you to Terry Lynn, our Clinical Services Director, for her leadership and ongoing support throughout. Her guidance was instrumental and helped us move this project forward. I also want to thank my 80s medicine team, as shown in the picture here, the nurses, my resource nurse, nurse educator, transition care coordinators, and allied health members, a lot to name. My assistant manager, Carla, for their openness on trying new approaches and their genuine commitment to improving patient flow. So the outcome of this project will reflect their teamwork and their willingness to adapt. And finally, appreciation to our quality team members for their work in supporting the QI Academy and for professional practice for the opportunity for my co-author, Zawa, to support QI work for the E-Inspire initiative.